Welcome to today's webinar, AI and Healthcare Accreditation, Ensuring Compliance, Quality, and Safety in the Age of Artificial Intelligence. Our speaker today is Dr. Richard G. Greenhill. He has spent 30+ years solving the problems that keep healthcare executives awake at night: declining quality metrics, patient safety challenges, and the persistent gap between healthcare's promise and its operational reality. At this time, all lines have been placed on mute to prevent any background noise. We will have a question and answer period throughout the presentation. Type your questions using the question prompt or the chat. We'll watch both. Your questions will be answered in the order they were received. When typing, please identify the name of your organization. The webinar is being recorded and will be available in the CIHQ YouTube library within a couple of business days. It's now my pleasure to turn the conference over to Dr. Richard G. Greenhill. Rich, you have the floor.
Hey, good afternoon, good morning, everybody, and welcome. So happy you could attend today. Just a little bit about more background about me. I've spent several years in quality, probably 27 of 34 years coming up here, and also I'm a data scientist. I'm very interested in AI. And I get the privilege of traveling the world, speaking to people and helping them with their issues around implementation. I'm happy to be with you today because, like you, I understand the things that go into having successful survey, protecting patients, and those types of things. So we're going to have that discussion today. I want to encourage you to use the chat. I'm okay with you, with you adding questions there, and we'll get to them and in the chat here. So let's get going out of respect for your time. So what we're discussing today, everyone, is not theoretical. There's AI that's already embedded in your hospitals and facilities right now. And CMS regulators are actively developing standards around it. We're going to talk a little bit about that today. And the regulatory landscape has shifted so dramatically just in the last few months. And my goal today is to help you understand what CMS compliance looks like today, what I think is coming tomorrow, and then talk to you about some practical tools that I think can help you immediately from some of the folks that I'm serving out there. So just let me bring you up to speed on what's happening in 2025 from a CMS perspective. Just 4 days ago, roughly 4 days ago, on December 4th, the HHS released a comprehensive strategy under the Trump administration. So, and according to that press release, this strategy, and I quote, represents the next phase of the department's transformative initiative to make AI available to the federal workforce. So this strategy really sort of points out that HHS has 271 active or planned AI implementations in fiscal year 2024. And it projected, and we'll probably find out next year, a 70% increase this year. So this is germane to how CMS will approach hospital oversight. So really the current administration's approach was outlined earlier this year in July when they put out the action plan, Winning the Race, America's AI Action Plan. And it emphasized removing regulatory barriers while maintaining accountability. There are some folks like me, data scientists, who feel like it's a little bit of the Wild West, and I'm a little nervous about it. But I think AI has some great opportunities to help us provide safer care for our patients. There are some things we have to pay attention to, and so we'll talk about that today. Now, some other things that CMS has done is last year in February, they issued some findings or FAQs rather, clarifying, Medicare Advantage organizations can use AI to assist in coverage determinations, but, they have to use a large data set rather than the individual patient's medical history or the physician recommendations. And so that applies to hospitals as well. And if you're not familiar with AI, the goal of that is you use a large data set because you don't want to focus on and be too narrow because it'll skew the algorithm. And then in June of this year, CMS announced the WISER model. You might have heard of that. It's a 6-year pilot to improve and automate prior auths using AI. And then critically, in April of this year, CMS issued a final rule for contract year 2026, and it did not include new restrictions on AI use that had been proposed. So there's an organization out there called Skilled Nursing News that I follow, and they reported on April 5th that this thing that CMS decided to finalize those things, and that could be a problem, around guardrails and health equity, but CMS has put some other things in there that fall under the regular standards that will help us. And this really signals, in my estimation, that CMS has taken a more measured approach, oversight without over-regulation. Although I would say to you humbly that a lot of the people making these laws don't really understand the depth of how powerful AI is, and so it's up to us really as the guardians of patient safety and in healthcare in particular to make sure that we put the guardrails up the way we need to. So they've sort of essentially put a framework out there, and it's not emerging, it's here, and it's focused on accountability. And we're going to talk a little bit about where accountability lands when you think about AI. So according to 2024, some data from the American Hospital Association, almost 90% of hospitals already use at least one AI-enabled technology, with most using 5 to 10 systems. And I would say it's probably in their EHRs or other systems. But here's the compliance gap. When I talk to hospital leaders around the world, especially in the US and Western countries, more in the US, I'd say, and I say, tell me what your AI systems are. They typically will name 2 or 3. In my estimation, that's a dangerous visibility problem. So the HHS strategy this week that was released confirms that even within the federal government, AI adoption is rapidly accelerating. It just is. And if HHS from the last slide is projecting a 70% increase for this year, your vendors are doing the same thing, or the vendors that are in our facilities are. That means that new AI tools are being deployed in hospitals right now in places like radiology, sepsis prediction, clinical documentation, revenue cycle, and even patient scheduling. I was speaking to a group of physicians just last week in Houston about this, just some of the power of AI to help in sepsis prediction. It is still emerging. Radiology and clinical documentation are more stable, but these other areas here are still emerging for implementation. And the surveyors know it. I won't talk too much about the Joint Commission, of course, but they've already begun in some of the facilities I'm in, having people walk through the AI governance process, and it's becoming a standard question during leadership interviews, and I'm not sure if that is true in other places. And from my time, being surveyed, if you can't answer the question clearly, it becomes a concern quickly, right? And again, it's not a future issue. It's something that's a present compliance gap, and I believe it needs immediate attention. Here's what we'll accomplish in the next 45 or so minutes. First, I want to share, the AI systems, my thoughts about the things that are in your hospital that require governance under CMS Conditions of Participation. Next, I'll walk you through what CMS expects based on the 2024-2025 guidance and the principles that are emerging from Health and Human Services. And then the last thing is you'll leave with somewhat of a structure to think about a 30-day action plan around what CMS surveyors might expect right now, and not really about projecting. It's going to be more real world of what I've seen, and this is about practical CMS compliance and not something theoretical. So the current administration's approach here to AI differs slightly from the previous administration. In January of this year, the president issued an executive order 14-179 called Removing Barriers to American Leadership in AI, which repealed the Biden administration's executive order that emphasized extensive guardrails. And I already told you that makes me very nervous just as a data scientist. The July 2025 AI Action Plan emphasizes a more deregulated approach to AI development. I think that could be okay in other industries. I think in healthcare, it's a little risky, because everybody's goals are different. Some, for-profit operators versus, and I'm not saying they're bad people. I'm just saying though we need, I think, definitive guardrails in my estimation as a data scientist. And according to President Trump's plan, his administration's plan, he noted that the federal government should not allow federal funding to be directed towards states with a lot of AI regulations. Again, that's good and it's not good. and it goes on to talk about government interference and states' rights, to pass these laws around innovation. I think that there's some promise to that, but it also is a little nerve-wracking. And now for healthcare specifically, HHS, their chief AI officer is leading that implementation, and the December 4th strategy adopted what they call a one HHS approach, which brings together CDC, CMS, and the FDA, as well as NIH, to really collaborate on infrastructure. And that's great, because we need all those minds about different things thinking. In a recent presentation I gave, the FDA has approved around a little over 1,200 devices in healthcare for AI. So that's a ton of things. So when I go back to that question of what AI is being used, can we answer that question as the guardians of patient safety and regulation? We need to be able to answer that question. I'm going to talk to you about a little bit later about how to do that. And so the strategy that the current administration put in has really 5 pillars, and it's about governance and risk management, infrastructure design, workforce development, health research, and then healthcare delivery modernization. So this just means that practically CMS is moving quickly. I mean, really quicker than I've ever seen them move on a topic. And so in June of this year, CMS also announced wasteful and inappropriate service reduction, or the WISER model. You might have heard of that, like I said earlier, and that was a pilot about prior auths. And so they've sort of shown that they're willing to do this to allow innovation while maintaining some oversight, but pushing that out to the states. And so, in my estimation, the message is clear from CMS that AI innovation is encouraged, but the hospitals are still accountable for safety and quality, and it's heavy on outcomes accountability under the existing conditions of participation. So let's just be clear about what CMS has established. And so in their February 2024 FAQs, they laid out the principles that apply to all healthcare AI. And so this was last year. It's still applicable today. But first, AI can assist in care, but it cannot replace clinical judgment. And that group of physicians I was speaking to last week, I told them, you are the final arbiter of what happens to that patient, not an algorithm. Several of them were concerned about what happens when the AI disagrees with me. And I said, well, it's up to you as the licensed provider, and that's key. Now, CMS has said more directly that an algorithm or software tool can be used to assist in making things like coverage determinations or other things, but it's up to the facility to really have the final say on that. And second, algorithms have to consider individual patient circumstances. It can't just be where you're using AI to, make broad decisions for people. It's important, right? And generic algorithms that don't account for individual patients will violate CMS standards. And the reason for that is clear, right? All patients are not a monolith of any race, group, or whatever people. So that makes sense. Third, AI can't be the sole basis for care denials or terminations. Now, CMS has noted this by saying that, the algorithms or software tools that predict, for example, patients' length of stay or patients' post-acute care stay can't be the sole grounds for terminating their services. This applies to hospitals as well. You can't let an algorithm alone determine when to discharge patients or deny services. And I know it's tempting for some facilities to do that. But at the end of the day, it's again about what the hospital and the care team thinks for that patient's care. Fourth, hospitals remain accountable for the performance of their AI tools, even when a vendor provides them. You really can't outsource that responsibility. So if hospital A brings on an algorithm or whatever to determine sepsis, and a patient dies and there's a legal issue, and the vendor had a flaw in their algorithm or their tool, the hospital is still accountable, because again, it's the end of the day, it's the providers. I can't say that enough, because there are people out there in the health administration ranks that I've met that believe that these tools are more powerful than they are. They're limited because they're the old adage, garbage in, garbage out. The data that feeds it, is what determines the outcome. So you still need a human eye on it. And next, while CMS has not issued explicit validation and monitoring requirements, they're implicit in quality assurance and performance improvement standards. So it's still all about making sure that we have power to, or the clinical team in the hospital is responsible. So under the patient section 482.13 patients' rights, they apply when AI substantially influences care decisions. So patients have a right to understand how decisions affecting their care are made. This has been a big talking point for me as someone who programs these algorithms, because I have told physicians and healthcare entities some of the methods being used for AI are called black box methods. And what that means is that they're using AI that's so powerful that even a data scientist, an experienced person who writes this code, can't really determine what happened. So how can we then explain it to our patients? How did the AI make this decision? That is still a big threat in my opinion, because black box methods, if you think about it, if you ever use ChatGPT or any of these others as a general, not in a healthcare setting, it makes decisions in seconds. That is a black box method. It takes millions or maybe even more data points and makes a decision, and that we can't trace back to how it made that decision. So that is something for all of us to really think about and pay attention to under 482.13. And then the April 2025 final rules decision, did not impose new AI-specific restrictions, but it doesn't mean that there aren't standards. And so again, they're trying to fit, AI's performance under the current conditions of participation, which is good in some ways. I think it will evolve over time. So let's explore how the CMS conditions of participation, how they intersect with how AI intersects with existing standards, for instance. And so under section 482.13 on patients' rights, again, we talked about patients having the right to understand, how decisions were made affecting their care. Now, this doesn't mean that there has to be consent every time an algorithm runs. But when AI drives a major clinical decision, for example, initiating a sepsis protocol or determining admission status or recommending a treatment pathway, patients must be informed. So in our setup of our policies, we have to make sure that our providers understand that, and it would be very burdensome to try and consent a patient every time. And also we can't just blanketly consent them, right? They have to know what's happening. Section 42.21 is about the QAPI, and it requires that hospital they all have to have effective quality programs. We know that. So CMS made it clear last year in 2024 that validations of any systems with artificial intelligence is expected. You have to validate AI in the environment with your patient population and not just rely on the vendor claims. I tell people all the time, AI takes data, looks at it, predicts, makes patterns, and so forth. So if I'm here in North Texas, in Frisco, so would data in Texas, in North Texas at a hospital, be valid in, let's say, Alaska or in Washington State or Chicago? Probably not. Patient populations are different and so forth. So we have to challenge our vendors to make sure we understand and validate those systems. There's ongoing monitoring that's implied under QAPI requirements for validation of these systems. You must monitor the performance of your AI. Now, under 482.24 medical records, CMS clarified in their guidance that the responsible practitioner has to review and attest to AI-generated content. You can't just auto-populate without human verification. And this is explicit. So clinicians must verify AI outputs before they become part of the medical record. And for obvious reasons, But like I said, obvious reasons. I mean, you don't want, I mean, you might have heard something in AI if you read about it called hallucination rates or hallucination. AI can hallucinate and make up things, right? You don't want to be using AI generated content without someone looking at it. The same reason we don't want clinicians cutting and pasting in the health record, right? Everyone's situation is different. It's no different when it comes to AI. So they must validate before it becomes part of the record. 42.28 on medical staff is around the competency requirements for appropriate use of AI tools. So, you know, they have to be competent, they have to be trained, they have to understand when they can rely on it, when they should question it, and when to override it. And so this, in my opinion, this is around digital literacy, not just for the medical staff, but for all the staff. We really have to make sure that people are trained. This is an organizational requirement to ensure that not just your clinicians, but everybody that's touching those patients knows when, how, what questions to ask, you know, around the quality of whatever the output of an AI is. There's a question, is this recorded for future review? Okay, yes, so I see that someone from CQ answered, thank you. 42.42 is on IP, infection prevention, and your AI surveillance systems have to be validated just like any other infection prevention component. And if your AI is identifying HAIs, that system has to be accurate and reliable. And that's important for obvious reasons. So CMS really has been clear that hospitals bear the responsibility for AI performance. Even when the algorithm is vendor provided, you really cannot outsource, you know, accountability under CMS conditions and participation. And really, we should not do that anyway. We have to maintain control of these tools. Now, based on CMS, their guidance and existing conditions of participation requirements, here's some things that I would say that you need to think about. First, you got to have governance. You know, you got to have a designated structure. Some facilities I know of that are really thriving at this in healthcare, is a few. They have steering committees, they have governance panels, and some of them have integrated them into their quality committees. CMS does not really mandate a specific structure, but you have to have clear accountability. You have to include clinical leadership, IT, compliance, quality, risk management, and informatics just at a minimum. You got to have a diverse group, and that's for obvious reasons. These algorithms take and they make predictions. And so if you have a narrowly defined group of people setting the policy for these, that then you're going to have a narrow set of outcomes. And you want the best, most informed set of outcomes for the AIs and how they're used. This body has to have clear authority to approve or reject AI implementations. The next thing is you have to have a comprehensive AI inventory. And so you really cannot govern what you don't know exists. So work with your IT folks, clinical informatics, department leaders to identify every AI system. I mean, things like what's the name of the system? What's its function? What's the risk level? So you have to come up with all those things: deployment date, department, validation status, and responsible owner. What I see happening is in some facilities is, you know, you have this place in the cloud, not the little cloud, but in the clouds in leadership that's making decisions on, you know, what to adopt and what not. And when it's the front line has no idea what's going on, or they don't even know what tools are being used, kind of like what I said in the beginning. We have to make sure that everybody knows when AI is being used. And, you know, this is important for when inspectors show up. You got to be able to tell them what you're doing. Risk stratification is really essential for CMS compliance. And so not all AI requires the same oversight. High risk AI, which is the kind that directly informs clinical decisions, so things, again, such as sepsis prediction and diagnostic algorithms, are very important to really understand and know what they are. There's medium risk AI, those things support workflows, you know, like ICD coding and so forth that coders review. And really your low risk AI is primarily operational stuff like your scheduling and supply chain, those kinds of things. There has to be rigorous validation and frequent monitoring of those high-risk systems. And anything, they just think anything that's touching a patient or helping a physician or clinician make a clinical decision is high risk, and it needs a lot of oversight. The low risk things, you need to watch them, scheduling, supply chain, but if they're not directly touching a patient, I would say that they're probably under my interpretation of what CMS wants, they're probably okay. You still have to document your rationale for how you classified them risk-wise. So next, you need a pre-deployment validation protocol that really specifies testing requirements, whatever the evidence that's needed, and who is the final approval on that. CMS expects us to test our systems before they go live in patient care. I mean, that goes without saying, but sometimes if you're not aware of what your vendors are doing, or you don't have people that are aware, things could be being implemented that you're unaware of. I've seen that more often than not these days, because really digital literacy is a problem. People don't know what they don't know. So, and they're subject to what the vendors tell them, which is a bit of a shame. So we need ongoing monitoring next with defined metrics and intervals for review. And this really aligns with the QAPI requirements under 482.21. Next, integrate whatever oversight you have in AI into your QAPI program rather than creating a new structure, right? CMS surveyors tend to look at whether AI quality issues are being captured and addressed through the QAPI process, and we should do that. Don't create a new process. It is part of it, so AI is a tool, right? It's not a panacea for anything. So it should be addressed in the same measure. Now, and last, or not quite last, almost last, really have patient communication protocols consistent with the patient's rights requirements under 482.13. That's important. And last, ensure that vendor contracts that you have include accountability provisions. Really access to performance data, really knowing what they're doing, notification of updates, validation report, and really how to pull the plug. One of the in the talk I gave last week to physicians, I told them, that for CMS and for FDA, they have to be able to get, if AI is shown not to work, you got to be able to stop it immediately because it can harm people, on a larger scale if you're using it and there's a flaw in it. This does require, I think, the clinical teams working very closely with vendors, or if you're developing AI in your facility, really knowing what's happening and what's going on. And these are the 7 components that form the foundation of a CMS compliant AI governance that uses the existing regulatory frameworks, and so something for us to pay attention to. So let's focus on the inventory, because this is really foundational for CMS compliance. So by conducting a systematic survey with IT, clinical informatics, department leaders, and so forth, you want to document every AI system in your organization. For each system, you need things like what's the system's name, like I said before, the function and all that. And risk stratification methodologies are important. So you could use the FDA's framework for medical device software as a guide. And so think about high-risk AI, that could cause patient harm, and those are important. And I've mentioned the different risk levels before. So anything that touches the patient, high risk, that middle risk tier is things that require human judgment, but really not clinical judgment, CDI, those kinds of things. Those are medium risk, and then low risk are, things that don't touch patients, supply chain and so forth. When a CMS surveyor asks you why you categorize your sepsis algorithms as high risk, but your scheduling system is low, you need to be able to defend that. So show that you consider patient safety implications and those kinds of things, and that this aligns with your QAPI 482.21. Want to pause for a second and ask, and you can put your comments in the chat. Wants to do a quick mental exercise here. Imagine a CMS survey walked into your hospital or facility tomorrow, and doing a validation survey said, show me your complete AI inventory. Every system that uses AI or machine learning in patient care. Could you produce that list in 30 minutes? And I'm not just talking about the obvious ones like your sepsis prediction tool. I'm talking about the AI features embedded in your electronic health record, or EMR, the natural language processing in your clinical documentation software, or the predictive algorithms in your revenue cycle, or the scheduling optimization tools. Take a few seconds and just think and ask yourself, do I actually know everything that's running in my facility? If you're willing to share, drop a number in the chat of how many systems you think you have operating now, just a number. And let's see, if you're willing to share. If you're not, that's fine. All right. I don't think anyone's dropping it in there. That's fine. I understand. You may not want to share that, or either I can't see the chat. But the visibility gap is real in the organizations that I work with, and I'll tell you that those 3 things or 4 things that I asked you, a lot of the folks I work with are not even aware of what natural language processing is, in a deep way. So it's something to pay attention to. So I didn't see a lot of comments in the chat, and that's fine. You may not want to share that information. So clinical validation, again, is essential for CMS under 42.21. You have to validate your AI environment, right? Whatever AI that you're using in your environment, rather, with whatever data you have. So I would say vendor validation studies can be helpful, but they're not sufficient, because when they did testing, remember I told you we can't use data from Texas and apply it in Washington State or vice versa. And vendors, depending on where they are in the country, they may have used different patient populations or data quality. The data quality may not be as good as yours. And so you want to test across diverse patient subgroups to identify potential bias. Does the algorithm perform equally, for example, in men and women? Different racial and ethnic groups, different age ranges, different insurance types. So in the HHS AI strategy, it emphasized equity and so forth. And health equity is a problem. I know that there's a lot of politics around that, but the HHS guidance still mentioned that around how these tools are used. And so if your false prediction tool underperforms for patients over 85, that's a potential safety issue for patients and a compliance problem, for example. So really understand and establish baseline performance metrics for, whatever you're measuring here, and that goes without saying, right? You need sensitivity, specificity, positive predictive value, and false positive rate, especially when you're dealing with AI. You got to know these things, because it's going to tell you whether you can really trust the performance of your AI. And you have to document whatever validation you're doing, your methodology, in great detail. This is what CMS surveyors will request as evidence of compliance with those quality standards. Critically, require clinical leadership approval before you go live. Your chief medical officer, medical director, whatever you call them, department chair, whatever, should review validation data and really sign off from a medical perspective that system is safe for the patient population. Now, this demonstrates medical staff oversight that's consistent with 42.28 requirements. So CMS has really made it clear through their February 2024 FAQs that vendor FDA clearance alone is not adequate. It's just not. And so there was one hospital that couldn't produce local validation data despite having an FDA cleared radiology tool, and it became a quality concern during a validation survey. I've seen that. Don't make that mistake. They really want to know, CMS really wants to know and expects you to know whether your systems affecting patient care actually work properly in your facility. That word properly, I put an asterisk by it, because what does properly mean? And properly at your facility may be different even than properly in a facility in your system, right? And definitely it's different in hospitals that are around the country because of all the data. Now, CMS quality requirements under 482.21 really require us to monitor our systems. Validation at deployment isn't enough. You have to have continuous monitoring. AI systems change over time, and that's because patient populations change, because the healthcare practice evolves, or the AI changes itself. I talked to a group last week about the different types of AI, right? And here's where it comes down to why you need continuous monitoring. So the old AI, tools, machine learning, for example, that I programmed in was just, you have a programmer like me program something, and then the AI responds to a set of conditions. That's traditional AI. Then you have generative AI. If you ever use Claude, Llamas, ChatGPT, those are generative AI. They take a bunch of data, pictures, words, put it all together, and they create something new. So some EHRs have the ability to use generative AI in them. But then when we talk about AI systems changing over time, which is why you need monitoring, agentic AI is something you probably have heard of, or is emerging right now. Agentic AI learns. So think of you putting a physician putting a pacemaker in a patient, right? That pacemaker does the same thing all the time. It reacts to PQRS waves and gives a shock when it needs, right? But think about when you implement an AI in one of your areas, that's, for example, agentic AI, that can learn and change itself. Think about how much of a challenge that could be if we just turned it loose and never looked at it again, or looked at it sporadically and didn't have a plan. That AI could change itself and do things and potentially harm our patients and so forth, and we wouldn't even know if we weren't really on top of it. So with that, each system you have, and I would say especially if you're using agentic AI, you must define performance indicators. And for example, the sepsis prediction tool, I mean, it's still emerging. It's I would say high risk, a high risk AI. You gotta have sensitivity measures, specificity, and alerts, per 1,000 patient days, and false alarm rates. That's important. And again, it has to be based on the risk. But I would say that any of them, whether they are high, medium, or low, if it includes agentic AI, I would always make those high risk. So mostly, like I said earlier, high risk is just things that touch patients. But if I had agentic AI working in any of my systems, even if they're considered low risk, I would have a plan for it, because they learn and they can change themselves. And so you have to be on top of that. So I would even consider thinking about automated alerts when possible. I know we're all fatigued and alert fatigue, but you need automated alerts. If your algorithm's false positive rate suddenly doubles, you need to know that immediately. And again, this is consistent with CMS expectations for quality monitoring. You gotta be able to identify and respond to quality problems promptly. So this is an area that's of great importance, I think. So we have to look at performance, analyzing performance across demographics, and that's becoming increasingly important for CMS compliance. Healthcare AI bias is well documented. There was a widely cited 2019 science study that showed an algorithm used by hospitals dramatically underestimated healthcare needs for Black patients. And so the HHS strategy released in December, a few days ago, emphasized equity as a core goal. And so the reason that this is important is, again, it goes back to data, right? If, for example, in that 2019 science study, what it showed, because Black patients often don't, for example, in some areas don't often seek care, the AI thought that it meant that they didn't need care, right? Which is the opposite if you've been around, certain communities, right? So you have to be on top of it. You just must. And I would even say conduct a formal bias audits at a minimum annually. And I would definitely encourage more frequent for high-risk systems or agentic AI, which is the AI that can learn and change itself. So when you identify bias, document corrective actions in your property plan, of course, and then you want to ask those questions. Can the algorithm be retrained? Do you need supplemental data? What's needed to really overcome bias, or should you just get rid of it altogether? And you want to think about clinical overrides for affected populations. And so the HHS Office for Civil Rights has really indicated that algorithmic bias that results in differential care and quality may constitute discrimination under the Affordable Care Act, 1557, that section. So your quality committee or oversight committee has to review this performance data at a regular interval and really have the authority to take systems offline if concerns emerge. Again, we have to act quickly, and you can't just say that the vendor is investigating. That's typically not acceptable for a surveyor, especially if a patient is at risk or patient safety is at risk. So for CMS survey readiness, again, documentation, we all know this is critical. If you didn't write it down, you didn't document it, it didn't happen. So you need comprehensive records demonstrating systematic oversight for the conditions of participation. And so maintain your AI inventory as a living document and update it as things are added or retired. Really preserve all of your validation studies, pre-deployment and ongoing monitoring. And these prove that systems perform as they were intended and demonstrate that you're in compliance with QAPI under 42.21. So keep detailed QAPI Oversight Committee minutes and document all discussions around AI, decisions, concern, and assigned actions. And then if there's a safety issue that emerges, how it was addressed. And that really needs to be documented, well documented in your system. So make sure that you maintain performance monitoring data in a format that is easily accessible and reviewable. If a CMS server asks you, how do you know this algorithm is working properly, you have to be able to produce current data, not just a vendor's validation study, as I said a little earlier from 3 years ago. And there's some folks that are doing that, which is why I brought it up. So document any bias assessments along with the analysis methodology and the findings of it. And you want to do that. It's kind of like, I'm an old lab guy from back in the day, so we have to run controls right before we release results. We have to know if our machines are working right. It's the same type of thing here. You want to keep incident reports involving AI in a retrievable format that allows trending. I mean, we do that for others as well, but I think we should pay particular attention to AI, especially as it relates to patient care, because these systems can get out of control, I think, if we're not paying attention. Maintain training records and your competency documentation for all staff, of course, that use clinical AI in their clinical care, and that's consistent with medical staff requirements under section 482.28. So you also should have examples of patient communication ready. If a surveyor asks, showing how you inform patients about AI involvement, and that's under 42.13. And again, we have to make it to where the patients can understand it, right? I mean, some of these things are very technical. And again, I go back to my sort of what keeps me up at night about the black box methods, that sometimes it's just hard for even data scientists like me to really understand what happened, or it would take a long time, right? So we have to make sure that we understand what's happening and explain it to the patients. So really the recommendation is to establish a centralized repository for AI governance documentation. So a lot of places I've seen will scatter these records across IT and clinical departments and quality offices, and it's really difficult to produce it during a CMS survey. So I strongly suggest centralizing it, making sure that people have access that need it, and doing that soon. So, your policies have to explicitly state that AI is a decision support, and it does not provide the final decision, right? Clinicians have to have an easy ability to really override any recommendation, and it can't be cumbersome, and it can't be buried in system design, right? That is important. The clinicians, when they deviate from AI recommendations, for example, documentation is important for really two reasons. Number one, it helps you understand whether your AI was useful to the clinicians or whether they ignore it. I mean, we all know that people get clinical reminders and they ignore them, right? Because they're not always useful, and it's alarm fatigue. And it also lets us know, if there's a problem requiring QAPI attention. And the next thing, and the last thing on this point is, it protects practitioners. If a clinician overrides an AI recommendation and the patient outcome is poor, documentation of clinical rationale is critical, right? We do need to train staff on appropriate skepticism around these things. Algorithms can be wrong, systems can malfunction, and data can be incomplete. And so clinicians have to maintain their critical thinking And this is part of their competency requirements under 42.28. One of the things I was talking about in a recent talk was, if you think about sort of now that planes, for example, can land themselves. I mean, the pilots that are coming out now are being trained on technology, so they don't know what to do if they have to fly the plane, some of them. We don't want our clinicians to be just relying on AI. We want them to preserve, their own knowledge about these clinical care and so forth. And we've seen, if you follow AI, it can take exams, it can take medical boards and pass them, right? So if our clinicians are not focused on their own learning, then it can be a problem. So patient rights, 42.13, they apply when AI influences any care decision. And so if AI is optimizing your OR schedule operating schedule, for example, patients don't need to know that. But if AI recommends specific cancer treatment or determines ICU admission or predicts readmission, and that risk affecting discharge, this rises to the level of requiring transparency. So develop plain language expectations. Most patients don't need the technical details about neural networks. I mean, they don't care. I mean, a lot of us, if you're not in that world, you don't care about it either. But they do deserve to just understand that a computer algorithm assisted in analyzing their results. Privacy is a big dimension under HIPAA, of course, in section 42.13. And so if patient data trains AI systems, do your patients consent to this process, right? Are you transparent about the data usage? So, the December 4th strategy that was put out, I mentioned earlier, emphasizes public trust in data security. You also have to have a grievance process for AI concerns, and this is, under section 42.13. Patients do have the right to voice grievances, and so if a patient thinks that, an AI system led to poor care, they need a way to raise that concern, and they need to receive a response. And so it's incumbent upon us not to, I'm not bashing vendors or consultants, I'm a consultant, but the consultants and vendors have to be accountable and make sure that they're supporting you in what you're doing each day. So a quick action plan here that you can start on tomorrow if you want. If you're focused on CMS compliance, is conduct an AI inventory and work with your IT folks and so forth. The goal is visibility, which is essential for QAPI under 42.21. If I were thinking about week 2, I would think about an oversight structure. Have a steering committee or integrate AI oversight into your existing QAPI and so forth. Make sure you have a diverse group of people and then hold your first meeting. And think about how AI is going to, oversight's going to function, how often you're going to meet, and what decisions and who's going to make decisions and what's going to be delegated. In week 3, I would think about risk stratifying your AI systems using what I told you, high, medium, and low, and considering agentic, and this is a Rich Greenhill thing, agentic AI, because it learns, should always be high risk. That's my opinion. And think about in your high risk sort of strategy, how are you going to monitor performance and identify gaps? Week 4, think about your governance policy, or think about how to integrate this into your QAPI policy and so forth, and how you're going to refine it over time. So establishing a sound validation protocol is important. Things like, what do you have to test before AI goes live? Who approves it? Always have your CMO or medical director approve it. For example, what documentation do you need, for example, before you adopt? And these things help us with demonstrating systematic quality oversight as per 42.21. And then in 30 days, 4 weeks, you're not going to have a mature program, but you will have moved from a more ad hoc sort of orientation to a systematic oversight, and you'll have something to show your CMS surveyors. You will be able to articulate then how AI fits into your QA and performance improvement program. And once you have your foundation, develop some specific policies. Again, think about a framework, validation protocol, how you're going to monitor, bias assessment, which I mentioned, very, very important with corrective actions, how you're going to communicate with patients, and then think about vendor management around accountability. It's so important that vendors be held accountable. And accountability is not a bad word. It really just means that you got to really understand what they're doing. And sometimes people will hide behind a proprietary, it's proprietary, but if it's that secretive, then you may not want to use it in your in taking care of your patients, because you're going to be held accountable as the hospital or provider. You don't need all 7 of these things simultaneously. I would start with a governance framework if I were you, and a validation protocol. Those are really foundation for CMS compliance. And then within 6 months, having all 7 in place for high-risk systems, just kind of stratifying, because we can't do everything at the same time, right? And I believe that this is a decent sort of framework timeline that you can demonstrate systematic progression towards comprehensive AI oversight. And so some of the things that CMS surveyors might ask you for, I think they will, is your AI inventory. Again, you got to know what you have. If you don't know, then that's going to be a problem out the gate, right? And then what oversight are you providing? What's your committee charter? Give some recent minutes, and so those kinds of things. Then validation reports for high risk, showing that you tested them in your environment and you found approval through a committee process is important. Then the other list here around performance, monitoring data, your policies and procedures, and these things need to be cascaded to the front line. Everybody in the facility should understand these, and not just a few people at the top or whatever. I would create a CMS AI survey readiness folder if I were you, and consider consolidating all these and updating it quarterly. So that way, when surveyors arrive, you're ready to demonstrate compliance with the existing conditions of participation as they really apply to AI. I mean, we do this anyway, right, in quality, but I would have a specific one for AI to make sure that it can be called out, because it's the new hot thing and it's not going away. So learn from some common mistakes. Some of these are pitfalls. Implementing AI without quality oversight is the biggest one that I've seen. People just allowing their records, allowing things and really not knowing, right? And the next biggest thing I've seen is relying on the vendor for validation. I mean, that's CMS expects you to know whether the system's working in your facility, and then no post-deployment monitoring. They might, on your deployment release date, everything might have been validated, but again, you have to have a way to do that periodically, right? Especially for agentic AI that can change itself. Others are ignoring bias in health equity, and you have to think every time you think of AI, even AI that you use personally, there's always going to be bias, because if you think about it, a human created it, and if a human created it, even if it changes itself, it's going to continue to perpetuate the bias that it was created with. So you can never trust that AI is going to be perfect. So we're never going to be able to take our foot off the gas with that. Documentation is important, and then some other things is, if you don't have your medical staff involved, that is definitely dangerous. I mean, again, 482.28, you got to have medical staff oversight, just must, right? And then no protocols. And all of these pitfalls are preventable, and all the current COPs apply right now. So I am not a fortune teller, but I thought this picture was nice. But some of the things I think are on the horizon is, really thinking about. We will at some point have some more guidance on AI and the conditions of participation in the coming weeks and days. It's growing very fast. It's going very fast. And CMS surveyor training is evolving to include AI assessment. So surveyors are being trained right now to identify AI systems and so forth. And so you want to make sure that you know your systems well. And the key message is CMS is really taking a measured approach and applying the existing standards rather than creating new ones. And that's good, because there's already a burden with all the standards that we just have to pay attention to, right? So here's some things to think about. If I were you, I would go out and review all these things and do these things. So look at their guidance from 2024, look at this HHS strategy. If you haven't looked at that, assess your current systems and have an oversight structure. You can take that sort of framework that I put in these slides when they're released, and just have your teams look at it and think about it, and really engage with survey consultants. If they're trained, they can help you with that. Key takeaways from today, and then we have about 5 minutes if anyone has anything. AI has to comply with what we're currently doing. There's nothing new about this. And then validation, patient rights, and medical staff oversight are key, right? And we have to pay attention to bias in these systems. All of them will have bias at some point. And so start with the inventory. Make sure you know what you have in your facility. Make sure you have a governance structure, and high risk risk stratification and high risk validation is key. So I will pause there and see. I don't know if I'm seeing the chat here. I see the chat, but does anybody have any questions? We have about 5 minutes. And if we go longer than 30 seconds, I'll turn it back over to you, Michelle.
All right, sir. So I've got one question that was posted earlier about if this would be recorded for future review, and absolutely yes. There is a CIHQ-ARS YouTube channel. This whole recording will be available in there probably within a couple of days. And you see Dr. Greenhill's contact information here too. I know that this was a lot of information, and I'm sure he's happy to answer questions as they arise once you have something to think about. Let's see, you do have a question from Linton. Is there a way we can hold vendors responsible if they misguide us?
I think there is. It's going to be when you sit down with them to talk to them about the algorithms, you need a person that understands AI at the table. Because what I see a lot of times is that they will snowball you and tell you all the great things that AI is going to do. And sometimes what the things they're offering are not even AI. I've seen that so much, and I've been at the table in some of those discussions, and I'm able to ask those questions because I have deep content knowledge around AI and these algorithms. So first you got to have a knowledgeable person at the table, and then you have to craft that contract with your vendors that you're able to then have consequences if they mislead you. That's our tool. So have your legal team involved with that, and make sure that you have a content subject matter expert at the table for AI, not just the vendors, because of course they're going to come in the suits and dresses and tell you all the nice stuff that it can do, but then you have to ask those questions about what happens when things don't go well. And if anybody tells you that they're always going to go well, run from that person. As someone who does the programs, these algorithms, these things are very fallible. They are not perfect. And we're always finding this. It's kind of like you have an iPhone, right? Or a phone, and it gets updated because things fall out of compliance all the time. That is even more true with some of these tools. So make sure you have your legal team there. Make sure that you have a subject matter expert at the table for AI that can go between, run interference for you to understand deeply what's happening. Good question.
All right, next question is from Christy Kerwin. Do you foresee the upcoming AI legislation to be universal or more state by state?
I believe, given the trajectory of where we are in the current administration, I think it's going to be state by state. They seem very reticent to give any blanket policy, and I think for good reason. I mean, we do need some standards, of course, that go across at a high level, but I believe if I had a crystal ball, it's going to be state by state, just given the nature of what's happening in the country right now. Good question.
Right. As a reminder, this presentation can be hosted or found on YouTube within a couple of business days. There are no more questions in the queue, so we're going to give you back, a minute of your day. If you have any additional questions regarding today's topic, please reach out to Rich here. Thanks very much. Thank you from the audience, sir. Thank you very much. I'll hang on until attendees drop off to about 10 or so. And I'll catch up with you after, sir. This was great. They say thank you.